Welcome to Healthy Focus, the Duke Rawlings Hospital Community Education Series.
Please join me in welcoming Dr. Gayle DiLalla.
Thank you so much. I am so glad to be able to speak with you all today and have you join us in the room where tomorrow morning we will sit around with our tumor board that we do weekly and discuss cases. So this Cancer Institute is a great place. There's education going on at all levels, and I'm particularly happy to be able to provide a little bit of education for people in the community. So my slide, Breast Cancer is Not Boring, I decided to title the talk that way based on a presidential address given at the American Society of Breast Surgeons a couple of years back, and I thought it really spoke to my personal journey to where I am today. I have been in practice for 20 years, and when I first started practice, my feeling was breast cancer was boring. Certainly wasn't boring if you were the patient, don't get me wrong, but there wasn't that much that we did. We did mastectomies, we did some lumpectomies, not as many as we do now, but mastectomies, lumpectomies. We removed all the lymph nodes. Some patients got radiation. Patients with big tumors got chemotherapy, and that was all there was to it. So basically, when a patient had breast cancer, it was the right or the left, and that was about it in variety. We have come a long way. There is so much going on in the field of breast cancer and breast cancer treatment that it's absolutely never boring. And I want you to keep in mind that everything I tell you today is based on April 26th, 2012. Because I feel like things change so much, and I tell every one of my patients, this is what we do today. 6 months from now, I may tell you something has changed. You got to be fluid. The treatment of breast cancer is fluid. As soon as there's something new, I'll let you know about it, and things change all the time, so it's not boring. Unfortunately, 1 in 8 women in the U.S. will develop an invasive breast cancer in their lifetime. And that statistic is based on people living to age 90. That's 12% of women. It's a frequent thing. We all know that. The American Cancer Society's most recent estimates for 2012 are that there will be 226,000 plus new cases of invasive breast cancer that will be diagnosed in women. There will be 63,000 and change new cases of carcinoma in situ. Those are not invasive. Many of them, most of them will need treatment. Somebody asked about that, and we'll get to that. That incidence is going up. The incidence of new breast cancer is going up, and the most disheartening statistic is that 39,510 women will die from breast cancer this year. Breast cancer is the leading cause of cancer death in women. It is 2.6 million breast cancer survivors, however, are in the United States. So while there are a large number of women that die from breast cancer, there's a way big number of women that don't. I thought I'd talk a little bit about risk factors. That's often something people are interested in. Here are things that have some sort of association. We don't have the answer of why someone gets breast cancer. But here's some risk factors that you can't do a darn thing about. Your gender, far more common in women. Men do get breast cancer. 1 in 100 breast cancers occurs in a man. We're not going to talk about that tonight. I'm glad some of them are here, but I assume they're here supporting the women in their lives, but it can happen in men. Age, just like prostate cancer, the older you get, the higher your risk for breast cancer. Genetic risk factors, genetic mutations. BRCA1 or a BRCA2 mutation are actually mutations in the DNA that are directly passed from a parent to a child. And people that may fall in that category can have genetic testing and be identified. I'll get back to that. Those are a very small portion. Only about 5% of patients that develop breast cancer have an actual genetic mutation. 95%, the vast majority, do not, at least not one that we can currently identify. Many patients will have a family history. If you have a personal history of breast cancer, you're at increased risk, and race and ethnicity play a role. You can't change any of this. Some other risk factors, potentially, dense breast tissue, a real slippery slope, lots of research, or lots of conflicting research, even some disagreement about what constitutes dense breast tissue. So if you have dense breast tissue, you keep that as something in your mind that you need to pay close attention. It absolutely doesn't mean you're going to get breast cancer. It's just a risk factor of a small proportion. As are proliferative lesions with atypia, it means you've had a biopsy and there's some cells that are what we term atypical. Lobular carcinoma in situ, it sounds like cancer. It's not actually cancer, but it's associated with an increased risk of developing breast cancer. Menstrual periods, how long your menstrual life has been. Did you start really early or really late? Did you go into menopause really early or really late? Again, things you can't really control. Have you had previous chest radiation? Have you had DES exposure? The farther out we get, the lower the number of patients with DES exposure, because that goes back pretty far in time. Obviously, there's some still around. There are some lifestyle-related factors, things you can control. Some have more effect than others. Having children. So we've known since I was a medical student that nuns have a higher incidence of breast cancer. It's what first clued us into the fact that not having children may increase your risk. It doesn't mean you're going to have breast cancer. It's just something to keep in mind. Oral contraceptive use. A lot of disagreement in studies, but when you pan them all out, if you have a recent use, you're at a little bit higher risk than somebody that hasn't, but the longer you're off, your risk goes down to somebody who's never taken them. Hormone therapy after menopause. I practiced for many years in Florida. There's a lot of retirees there. They were all on Prempro. We thought we were doing really good, and they loved being on it. We thought we were preventing a lot of heart disease, and then all of a sudden, in the early 2000s, wham, we found out we were completely wrong. We pulled everybody off hormone therapy. I had lots of really unhappy patients and had to move to North Carolina. No, that wasn't really the reason, but people are not happy when you pull them off their hormone therapy. We did figure out that if you've been on hormone therapy for 10 years or longer, your risk of breast cancer goes up. So if you have a period in your life where you're taking hormone therapy for a shorter period of time because you really need it, that's probably a reasonable thing. Breastfeeding is associated with a lower incidence of breast cancer, but I can't tell you how many women in my career have said when I've given them their cancer diagnosis, but I breastfed my children. So yes, it decreases your risk, but it doesn't mean you're not going to get breast cancer. Alcohol is associated with an increased risk of breast cancer. Is it a large increased risk? No, but there is that risk. Does that mean if you never drink, you're not going to get breast cancer? No. Does it mean if you drink, you are going to get breast cancer? No. It's just an association. Being overweight or obese. Well, I got to tell you, that's one you can control, and there's some direct effect. Because once, particularly in postmenopausal women, once you've gone through menopause, your ovaries, which are the typical estrogen producers, that goes down, but fatty tissue produces estrogen, and so The more of that you have, the more estrogen you're making, and that's consistent with an increased risk in breast cancer. Physical activity. You know, it's hard to know where that comes in with being overweight versus physical activity, but even a small amount of regular physical activity decreases risk. What becomes really important as often as we can is to find breast cancer early. Currently, April 2012, screening mammograms are the best we've got. Are they perfect? No. Do they miss things? Yes. Do they have some discomfort associated with them? Yes, like I think I mentioned already, they'll miss things, but it's the best thing we have in a large population to get everybody screened. Things are coming down the pipe, and hopefully sooner rather than later, there may be some good alternatives or at least adjuncts to mammograms. Self-breast exam, so people that pay a lot of attention to the news and breast cancer things will notice that a few months back, maybe last summer, I don't even remember when the brouhaha erupted, but a national task force came out and said, oh, breast self-exams cause women to get more biopsies, so let's tell everybody not to do them. So after I finished beating my head against the wall, you will find that the American Cancer Society, American Society of Breast Surgeons, American Society of Breast Disease, name a group in this country that's working toward keeping women from dying with breast cancer. None of them will go along with saying you shouldn't do self-breast exam. Now, I will say that I don't think there's a right or wrong way to do a self-breast exam. I don't care if you go up or down, in circles, back and forth, you have somebody else do it, whatever. The whole idea is you want to be familiar with your own breast. This includes men. And if something's suddenly new or different that doesn't seem right, you don't have to figure out what it is. But you have to ask your healthcare provider about it and let them help you figure out what it is. So I think clinical or self-breast exams are very, very important. Which brings us to clinical breast exam. That means a healthcare provider, your physician, your nurse practitioner, whether it's your family practitioner, your GYN, whoever's doing it, once a year, if you're seeing them once a year, you should have a clinical breast exam because they do pick up things that you kind of failed to notice. Sometimes it's like watching grass grow. You just didn't notice it even though it was sort of right there under your nose, so to speak. But somebody else who comes along goes, what's this? So a clinical breast exam. Patients that are at high risk will often benefit from screening MRI. We can't MRI the whole population. We don't have enough resources, we don't have enough time, we don't have enough machines, it's never going to happen. But there are those at high risk that benefit from this screening because it doesn't matter if your breasts are dense, it doesn't, it picks up a lot of other things. It's a completely different type of imaging. 3D ultrasound, not really utilized locally. Folks in some places are kind of starting to figure out if it's going to be helpful, useful in screening a big population. It's one of the options that I think you'll see over the next few years as part of a screening program. Genetic testing for those people at high risk for having a genetic mutation. They need to get tested early so they can come up with some sort of aggressive close follow-up program for how they're going to be tracked. There are some things for patients that we can do that are at high risk that we term breast cancer chemoprevention. We used tamoxifen for a long time. It does a good job in preventing or decreasing the incidence of estrogen receptor and progesterone receptor positive tumors. Unfortunately, tamoxifen has some side effects of its own. Otherwise, we could just put it in the water. And so patients really have to weigh out their risk of breast cancer versus the risk of taking the medication. Raloxifene, which people might know as Avista, has also been approved now for use in chemoprevention. Its side effect profile is different and probably a bit less risky. It's not been shown to be as effective, but there is some effect. So for patients particularly that have osteoporosis, Vista's kind of the perfect fit because that's its original intended use was to prevent osteoporosis. If you have an increased risk of breast cancer and you're going to need something anyway, that's a good fit. Aromatase inhibitors are the newer class of drugs that we use in estrogen and progesterone receptor positive patients to treat and prevent new breast cancers from forming. And there are clinical trials that are looking at whether we can use those as prevention. And so that is being done, but more within the context of a clinical trial. And it makes sense that if we can use the other ones, we're probably going to be able to use these. They have side effects also, so you kind of have to pick your poison, but the side effects tend to be a little less risky. And if patients don't tolerate it, they can always stop. Sometimes worth a try. When we're trying to figure out patients' risk, we always want to get a good history, family history, things you were exposed to. Getting a good history is just key. So when you fill out those questionnaires at your physician's office and you're like rolling your eyes thinking, again, getting all that history, it's really worth being really good with all that information because it helps us figure out where you are in a risk. There are risk assessment tools. These are basically statistical models. The most common one is the Gayle model. If you go on our website, we've got a link to it. You can find it at the breastcancer.gov, but there's a bunch of lists if you links to it if you just Google Gayle model. You'll be able to toss yourself into that one pretty easily. The downside to that is that it doesn't take into account, for example, if you have cousins or aunts with breast cancer. Doesn't fit in that model. It's only first-degree relatives. And it does nothing to take into account how old that first-degree relative is. So if mom had breast cancer at 40 versus mom had breast cancer at 80, that means two completely different things to me, but not two completely different things to that model. Having said that, it's still the one that most insurance companies use when they're looking at whether they're going to cover something like an MRI. The other two, have just different things you input. One's not the best, and you can absolutely get different estimates in the same woman. Sometimes I'll calculate multiple risk models for patients. Treatment has changed a lot. The surgery's changed, the radiation's changed, the medical oncology's changed. I absolutely don't have enough time to go through all of that. I'll spend at least an hour with each patient just going through the options for them, and I've got a room full of people. But here's the kind of take-home points. Surgery. Used to do a lot of mastectomies, got way over here to breast conservation for most women. Guess what's happening? We're moving back toward the lots of mastectomies. That's not us as physicians, that's patient's choice. Women get, particularly the younger ones, get kind of spooked by the whole thing, and if they're diagnosed with breast cancer, particularly at a young age, they often are electing to have not only a mastectomy as treatment, but a mastectomy on the opposite side. They're basically done. They don't want to go through any more mammograms, ultrasounds, worrying about it, so they elect to do this. It's trendy right now, for lack of a better term. I think you'll see a turn away from that as we go forward to some degree. But the take-home point is that there's options for every patient, and what feels right for one person may not feel right for another. And the nice thing to me is that there are now choices. There's breast conservation, there's mastectomy with nipple sparing, just all variety of surgery, immediate reconstruction, tissue expanders, implants, your own natural tissue. There's really, buffet is probably a poor choice. But there's a lot of choices for women, and there's not a right or wrong. It's what works for you, your individual cancer, where it's located, how old you are, the size of your breast, all sorts of things. This is why it's not boring. Before it was, it's your right breast, it's your left breast, you're going to have a mastectomy and take all your nodes, or I'm going to do a lumpectomy and take all your nodes. It's not like that anymore. The other thing we've done in surgery is gotten away from removing lots of lymph nodes. We key in on what's called the sentinel lymph nodes. Lymph nodes are sort of like beads on a necklace. They go from one to the other. If there's no cancer in the first one, there's no cancer in the rest of them. And as we figured that out, we're having to do much less surgery and take many less lymph nodes in most people, which therefore causes less problems, side effects down the road. So surgery is changing a lot, and there's lots of options. There's even more options in radiation. So in the past, radiation is, here you are, we have a big dose of radiation. If we gave it to you all at once, it would fry you. So we break it up into doses, and it takes about 6 weeks, a few minutes a day, and you've got your radiation. Well, now we've kind of taken interest from other forms of radiation for things like prostate cancer, and we now have accelerated partial breast radiation. Some people may not need their whole breast radiated. Maybe they just need the area where the cancer was. Maybe instead of zapping them, I was looking around for radiation oncologists that would not like that term, but instead of zapping the breast external beam, we put radioactive pellets via a variety of delivery systems into the spot in the breast where the cancer was. That can be done over a period of 5 days. In some places, they're even looking at doing it just one treatment at the time of surgery. So there's a number of options in radiation for those who need it. And we finally got to medical oncology. I refer to those kindly as the drug czars. Basically, drugs, whether they're in an IV form or a pill form, are the only thing that can go everywhere in your body. Surgery can't go everywhere, radiation can't go everywhere. So if you want to make sure you've wiped out every potential cancer cell that might have gone and hidden somewhere and is going to hang out for days, weeks, months, years, our medical oncology friends are really good. They have a variety of medications. We get more and more medications all the time, and we're at the cusp of doing what we call targeted therapy. So figuring out your particular tumor and which particular drug works on your particular tumor. So that is the buzzword. What's going on is trying to develop targeted therapies, some of which we have, but many more are needed. So the reason is not all breast cancer is the same. Initially, breast cancer, back when I first trained, was on the right or the left, and it was ductal, starts in the ducts of the breast, about 80%. It was lobular in about 20%. That hasn't changed so much, but we now can subdivide it even more, and not all breast cancers behave the same. So first of all, we have luminal A and luminal B types. These are both estrogen receptor positive. They're fed by hormones. You can have a luminal A. They're more low grade. They tend to grow fairly slowly. They have a good prognosis. They're kind of the couch potato of breast cancers, and if you had to pick, you'd probably want to pick this. But we tend to see this in older patients, not so much in younger patients, but you can't always guess by age. The luminal B cancers, they grow somewhat faster. Their outlook is not quite as good. So it is reasonable to think that you might not want the same treatment for A's as B's. This is a view showing a side view of the breast, and you have skin, you have a layer of fatty tissue, and then you have the glandular tissue, which is made up of the lobules and the ducts. Think about the lobules as cul-de-sacs in your neighborhood, and the ducts are the streets that leave out of the neighborhood. They join with other streets, and eventually there's some highways out the nipple. So along those roads are the cells that generally where 80% of breast cancers rise, and back in the lobules is where the other 20% of breast cancers start. Some of the cancers can be HER2 type. They have extra copy of the HER2 gene. They tend to be high grade. They're not terribly friendly, and yet we do have some targeted therapies for these type of cancers. 2 drugs so far, and there are more in the works, are used very successfully in most cases against these tumors. These are usually not given by themselves, but usually given with other chemotherapy drugs as well. But lapatinib and trastuzumab, Herceptin are the 2 drugs that are given to HER2 positive patients that specifically target those kinds of tumors. And as we've come along are the kind of first targeted therapies. Well, I guess tamoxifen against estrogen positive tumors was maybe the very forerunner of targeted therapy. But as we're getting closer and closer to specific drugs for specific tumors, this is the next generation. Finally, we have what we refer to as the basal type, and you may have heard of these, the so-called triple negative tumors. They don't have estrogen receptors, they don't have progesterone receptors, and they have normal amounts of HER2. So the tamoxifens, the aromatase inhibitors, the trastuzumab, the Herceptin, lapatinib, none of those work. So we're left with a few drugs that will work well in some patients and not so well in others, and this is sort of, as a breast surgeon and taking care of breast cancer patients, the bane of my existence, because right now we don't have as much good therapy for these types as we need. We do see these more frequently in a BRCA1 gene mutation, and for whatever reason that we don't know, they're more common in African American women and in younger patients, and yet I've seen them in 89-year-olds. So it's the breast cancer that we're most working on finding more effective treatment for. Because while this isn't true about every one of them in general, they tend to grow more quickly, they tend to have a poorer outlook. Even amongst these triple negative, we're trying to segment them out to find different ones that behave differently and again come up with targeted therapy. So a lot of research is focusing in this area right now. Part of the research that has to do with all of the types is what we term genomics. So there's 2 terms that can get confusing. One is genetic testing, where we're testing the person for their DNA. Genomics refers to testing the DNA of the tumor. There are, when I put this together, there's actually like 5 or 6 now, and in a week I'm going to hear about at least 5 or 6 more. There are more and more genomic tests coming out on the market. The ones that are FDA approved are out there, and I'll renege on the FDA statement because one company likes to say they're FDA approved and the other one isn't, but it's just different pathways they've gone to present their testing to the market. But basically it's looking at the genetics of the tumor and coming up with predictions and prognosis and moving that toward trying to figure out which specific drug will help which specific tumor. The Oncotype DX is probably the one most commonly used. So far it's most commonly used because it was there first, but also because it's a test that can be done on a fixed block of tissue. So once somebody's had their surgery, once the tissue's preserved, once it's already been to the pathology lab, it's no longer fresh. There's just slides that have been kept. The test can be done on that tissue. Whereas, for example, a mammoprint has to be done on fresh tissue, which means I have to have this little core of tissue and know that it's cancer, or be pretty certain that it's cancer, and save a bit of it for this test because it's got to go in a special solution. And so you can't kind of decide after the fact that you want the test. So right now, Oncotype is the one that's most commonly used because the medical oncologist can decide 6 weeks later, 8 weeks later, 2 weeks later that they want to get an Oncotype. Let me go back to that. What does Oncotype or these other genomics help us do? So we think we're smart and we're good predictors. You've got a small tumor. It looks like it's kind of low grade. It's probably not going to be very aggressive. You probably don't need adjuvant chemotherapy, the IV chemotherapy kind. Or we think, well, your tumor's kind of high grade and it's kind of big and you're kind of this age, so it's probably going to be mean, so we should give you chemotherapy. What I can tell you is that of all the people that get chemotherapy pre-days, it was just based on kind of grade and size. So if your tumor, when I was in training, was 2 centimeters or above, you got chemotherapy. Then they found out they were missing a bunch of people, so if your tumor was 1 centimeter or bigger, you got chemotherapy. Out of those group of those patients getting chemotherapy, out of 100 women, only 30 of them needed it. We just didn't know which 30. So in order to make sure you don't lose those 30, you give it to 100 people, you save everybody. Well, you know, a bunch of them didn't need it. The genomics are helping us decide to a much better degree who is at risk and is going to benefit from chemotherapy and target the chemotherapy to those patients because, one, they really need it, they're not going to do as well, and the chemotherapy definitely reduces their risk of recurrence, versus a patient who was never going to do poorly. Chemotherapy doesn't make a bit of difference other than cause a bunch of side effects and problems that they didn't need. So this, for me, is a really fascinating new horizon that's now in clinical practice for the past 2-4 years, depending upon where you are and who you see, that is absolutely becoming the standard of care and is now part of nationwide recommendations in certain patients. So many patients will be getting one of these tests to decide whether they're appropriate for chemotherapy. About a year and a half ago, this big word, this is one of the clinical trials, came out, big paradigm shift in the surgical world. Before, if you had positive lymph nodes, our first big paradigm shift was saying we don't need to take all these lymph nodes out, we've got to find the sentinel nodes and look at those. Well, now we're finding in certain patients we can find the sentinel nodes, and before, if you had any tumor in your lymph nodes, they all needed to come out. We now know that in a good chunk of patients, because a fair amount of people will fall into this, they have a little bit of tumor in 1 or 2 nodes. And we know that by taking out the rest of their nodes, this study has shown we're not helping anything. We don't need to do that. So we're moving back and away from, and it's a very big shift for surgeons who are, okay, positive nodes, take them out, positive nodes, take them out. It's what you're supposed to do, to say, nope, don't need to do that. Our radiation colleagues and our medical oncologists, by giving the rest of the treatment they're going to give, we don't need to do that. Patients are going to take their tamoxifen or their aromatase inhibitors. They're going to get their radiation. They don't need a complete node dissection. Let's see. Before I get to questions, so this was one. This study came out probably a year and a half ago. And in May, so next week, I will be going to the American Society of Breast Surgeons meeting. It's an annual meeting, one that the breast surgeons across the country go to. When I first went to the meeting, I think it's been going on now 11 years, give or take. There was about 200 of us there. There are now 1,200 folks that will come to this meeting, and more that won't make it to the meeting, that either do a lot of breast cancer surgery, so a big chunk of their practice, or more commonly now, specialize specifically only in breast surgery. That's what I do in the practice that I'm in. I concentrate now only on breast disease and breast cancer. When I trained, there were no breast fellowships, there are now. So we do have coming very shortly to the main campus this summer, our first fellowship-trained breast surgeons. The rest of us have trained basically by doing lots of additional coursework, meetings, and specializing in it because that special training didn't exist. But back to this meeting a year ago, this had come out, the paper was published, and everybody was looking at each other going, are you going to do this? Are you going to do this? You try it. And coming back from that meeting, we were like, okay, the data's there, everybody's in agreement, and this concept got fully implemented into our clinical practice and the clinical practice across the country. So I'm excited because I know there's some things out there that I'm like, what do I think about this? I'm not sure. I'm going to see what my colleagues are doing each year. And so next week, the things that I'm particularly looking for, we may not have gotten that slide. I was going to share with you, I'll look at it when we start some questions, some topics for the meeting to let you know what things you're going to see in the news over the next few months that are brand new in clinical practice. So I want to thank everyone for their attention and great questions.